All right, welcome to another Medical Director Minute. I'm Dr. Brian Everett. Today I'm joined by our ED pharmacist, Christy Hargrove. She is a very experienced emergency medicine pharmacist, works with me in the emergency department. And today we're going to talk about Droperidol. Christy, you want to introduce yourself?
I'm Christy Hargrove, as Brian said. I work here at University Hospital in the emergency department on various shifts. I've worked night shift, day shift, mid shift, and we're really involved in the resuscitation part with our patients. So we review all medications for all patients in the ER as well as bedside with those resuscitations. So I'm excited to be here.
All right. So today we're going to talk about Droperidol, which is a wonderful drug that I absolutely love because if I'm an EMS medical director, the one thing I love is a drug that does multiple things and is relatively safe. So can you tell us a little bit about what Droperidol is and how it works?
So droperidol is one of our antipsychotics, and our antipsychotics are separated into first and second generation. Our first generation antipsychotics are older drugs, and that is what droperidol is, similar to haloperidol. It works via a dopamine mechanism, so it's a dopamine antagonist in the brain, which is where you get that antipsychotic effect, because it's generally overstimulation through those dopamine pathways, and so that's why we utilize it for as an antipsychotic. However, we've found that it has a lot of other mechanisms, including working with nausea and vomiting, again through that same dopamine pathway similar to like your antiemetics, metoclopramide, as well as helping with quite a few other things.
How long does it usually take after I give someone a dose of Peridol for it to start to work?
So it can vary. It's going to depend on your route of administration partially. So this drug can be administered IV, IM, IO if that's all you have. And your IV is obviously going to be a little bit faster. So your IV is usually between 5 to 10 minutes. But your IM generally takes about at least 10 minutes. It can be up to 30 for IM onset. However, it is generally reasonable to redose in an acute agitation situation earlier than 30 minutes if you were utilizing the IM route.
So if I'm giving a patient that is having an acute agitation, I am droperidol. I should wait at least like 15 minutes before I think about redosing.
Yeah, usually I say 10 to 15 minutes. You got to give your drugs time to work. But this is similar with really any of our medications that we're using for acute agitation. It's a little bit slower than your midazolam, but a little bit faster or similar than your ketamine for IM administration. So that's kind of where you can think about before redosing is that 10 to 15-minute mark.
And you mentioned midazolam. Is it safe to mix droperidol with midazolam?
Yes. So both from a pharmacologic standpoint, yes, it's safe, and from actually a syringe standpoint, they are compatible in a syringe. So if you do not have access and need to give IM access, they can be administered together. The caution with this is this really only should be utilized for a very acute agitation because your additive side effect is going to be obviously you're purposely trying to sedate the patient, but then you add that respiratory depression with your benzodiazepine as well.
So I definitely need to make sure my patient is on the monitor, has
Yes.
end-tidal CO2 monitoring, and oxygen saturation monitoring as well, correct?
Yes. Yes. Your patient should be on constant monitoring, definitely with the combination and at least on a cardiac monitor with your droperidol.
Why on the cardiac monitor? What's so important about that?
So, your first generation antipsychotics can cause QT prolongation. This was kind of one of the older things that was seen. Again, this drug is relatively old. So, early studies with doses up to 50 to 100 milligrams actually saw quite a bit of QT prolongation, leading to possible torsades or even ventricular arrhythmias. However, at the doses we use, this is less likely, but not impossible. And so this is why it's important. It's completely understandable to not necessarily be able to get baseline EKG and kind of see what that's starting to look like, or even get them, on the monitor and see their rhythm. But once they have received medication, they should be on the monitor, and hopefully at that point they're a little more sedated and compliant with your monitors.
Yeah, I generally recommend our guys and gals out in the field to do 12 lead EKG and look for that prolonged QTC and would inhibit a second dose in those
Mhm.
kinds of patients. All right, so we talked about we can use it for nausea, headaches, and acute agitation. What are the doses?
So your doses are going to be dependent on your indication. Your higher dose being obviously more sedating as you get more drugs. So that's really what you're going to be thinking about for your agitation. So for nausea or for headache, really it's helping with kind of the nausea associated with headache, a little bit of the sedating factor. Really, those doses are going to be 2.5 milligrams. You can do up to five. It's actually marketed, I think, on the packaging as 0.625 to 1.25, but that's a very small part of the vial. And personally, I don't know that that's really going to be super helpful. So I generally recommend around 2.5, at least as a starting dose for your nausea or your headache indications. Again, you can redose and get up to that kind of 5 milligrams if needed. For your agitation, this is somewhat going to depend on route a little bit. 5 to 5 IV based on patient assessment. If they're more agitated, I don't think it's unreasonable to start at that 5 milligrams. If you're doing IM, really getting up to that 5 to 10 milligrams. The max kind of single dose recommendation is no more than 20 in kind of a single incidence. So if you gave 10 on the first dose, then you could reasonably give another 5 to 10 up to a total max of 20 milligrams.
Yeah, we really want you to call for medical direction
Mhm.
if you're going to give a second dose for that safety aspect. What about for headaches?
Headaches are, again, towards that lower dose, anywhere from 2.5 to 5 milligrams. Again, start with your 2.5. You can give an additional 2.5 if it's appropriate, and contacting medical direction if needed. But really, with both your nausea and your headache, you do also want to think about this isn't really a first line agent, it's more of a second line agent. So, administering your Zofran or something else first for nausea, or even for headache or migraine, that's not helping. This is at least using a different mechanism. So you can kind of work with different mechanisms to help resolve that.
Yeah, for our headaches, our patients should have at least tried another medication such as Tylenol before we think about droperidol as that. Because again, we're going to sedate that patient. They're going to take more monitoring for us to monitor them in the hospital. Okay, so are there any patients that we really need to be cautious about giving this to?
With most of our medications, our elderly patients are going to be more sensitive. And really, this is, I mean, true for a lot of medications, especially when we kind of get into any antipsychotics, things where we're trying to sedate a patient or that may be sedating as a side effect for a different indication. So, your elderly patients, especially elderly patients with dementia, you want to be cautious with all elderly. There is some data that supports that antipsychotics can actually be harmful in patients with dementia. So that would definitely, I would say, require a call before using of is this the most appropriate way to sedate this patient if it's agitation, or what other alternatives do we have for some of our other indications?
Yeah, we're going to recommend you half the dose, your starting dose for your elderly, and definitely call medical direction if you have any questions regarding the dose of the elderly patients. What about pregnancy?
So pregnancy, I would generally say it's not recommended. It's definitely not first line. We have other antipsychotics or other medications, kind of depending on what your indication is for pregnancy. It has been studied some, but it's just not well elucidated. A single dose may be okay, but it actually is not recommended by ACOG for repeated dosing for control of any nausea or vomiting associated with pregnancy.
Well, great. Well, I think that's all the questions I have, unless there's anything else you want to add into it.
I don't think so. Droperidol is a great drug. I think it's something that can be utilized for the right patient, especially if there's a concern for psych issue. If they have some sort of baseline psych diagnosis, it may be your better option or adjunct option for agitation.
Awesome. Yeah, I'm definitely looking forward to us being able to use it for agitated patients, for nausea and headache as a secondary line. Just remember, it's sedating. We need that EKG and we need that monitoring with patients. So thank you very much, Christy, for taking the time out to talk with us and educate us. We look forward to seeing you in the future for more about what's going on with our drugs. Appreciate you.
Yep.
All right.